Hello, hello. We're going to give it just a minute for folks to start coming in the virtual room. We have all lines muted just to prevent background noise, but we would still love to hear from you. You can feel free to use the chat box or the Q&A feature both now and throughout the session. I will say in the chat box, and we'll try to remind folks that the default is to send messages just to panelists. And if you want the whole group to see, you can choose from the drop-down box for panelists and attendees. So we'll give it another minute and then we'll get started. All right, just for the sake of time, we'll go ahead and I'm sure we'll keep having folks join us. Again, hello and welcome to those of you who are able to join us live for this first session of a webinar series on addressing barriers to diabetes prevention, specifically for older residents of public housing. My name is Ariel Mather, and I'm the Program Manager of the National Center for Equitable Care for Elders. This is a collaborative webinar series with the National Center for Health and Public Housing, and we're so excited to have a guest speaker from the Massachusetts Council on Aging with us today, and I will introduce her in just a little bit. So we're all very familiar with Zoom reminders by now, but just to make sure we're on the same page, all lines are muted just to prevent echo and background noise. But we would love to hear from you through this session. If you have a question or feedback, if there's something that you can relate to or something you want to share related to your experience with this patient population, we'd love for you to share through the chat box. You can also utilize the Q&A feature. If we have time at the end, we can certainly have folks request to be unmuted if they want to ask a question or share something directly. But as always, this webinar is being recorded. You will get access to the PDF of the slides shortly after this session completes, and a recording will be made available on YouTube within the next week or so, and that will also be closed captioned. Once you close out of this webinar today, you will have a a survey pop up from SurveyMonkey directly from Zoom that we'd love for you to hear, for us to hear your feedback. If you can take a few minutes and let us know what you thought of the session, that will help us as we plan future training and technical assistance. I like to plug the Health Center Resource Clearinghouse during all of our TTA because it's a fantastic resource for health centers and community organizations that are serving a variety of special and vulnerable patients. But this priority topics page around COVID-19 has been a great source of information throughout the pandemic, but now has a lot of specific resources on the health center vaccine program and in general, just reaching your patient population related to testing and vaccination. So if you haven't already checked that out, we encourage you to do that. And if you are not familiar with the National Center for Equitable Care for Elders, we hope that you'll connect with us on our website and social media after this session. We have a lot of training and technical assistance focused on the needs of community dwelling older adults, whether that's something like this, diabetes prevention or management, as well as their social determinants of health. And we've had an increased focus in this past year on the emerging issues of family caregiving. So we hope that you'll check out the links that are on this slide and stay connected with us. And I'm going to let Dr. Jose Leon introduce the National Center for Health and Public Housing.
Thank you, Ariel. Good afternoon or good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And our National Center is a national training and technical assistance partner, providing training and technical assistance to community health centers. We focus on those providing healthcare services to public housing residents or those living in or immediately accessible to public housing. We have three areas. We have training and technical assistance. We also perform a research and evaluation. We work very closely with HUD. We also do a lot of outreach and collaboration with health centers and community organizations across the nation. We are funded by HRSA to provide these activities, and the National Center for Health in Public Housing also works very closely with public housing agencies. So we see the need to work not only with the health centers, but those organizations or authorities who are responsible for the well-being of those living in public housing. Next slide. Today, we are going to discuss a couple of items that we consider necessary and very important. First, we are going to describe the environmental and personal factors that influence the ability of older adults to engage in healthy lifestyle behaviors. We also are going to identify strategies for effective case management that address social determinants of health that impact diabetes prevalence. And lastly, we are going to talk about collaborations with community programs and advocacy organizations to promote available resources for nutritional assistance. Next slide. This is a very important topic. Diabetes in the aging population has been one of the latest concerns when we discuss diabetes. There are several issues that we need to take into consideration when we discuss diabetes in the aging population. According to the latest data that we got from HRSA, there are around the number or the percentage of those age 65 and older served by health center is about 10%, and 9% of those receiving service at public housing primary care sites are also over the age of 65. Next slide. Since we are going to discuss a little bit social determinants of health, there are a couple of things that I would like to mention. In public housing, 35% of those living in public housing are over the age of 62. This is really important. There is a bit, there is some difference because for HUD, they consider the age 62 and not 65. So there is a discrepancy there, but over 35% are people over the age of 62. And in public housing, and this is another percentage that is extremely important, is that 38% of the household report that at least one person has a disability. So when you combine these numbers, again, HUD is saying that 17% of those over the age of 65 or 62 in this case have some disability, or at least one disability. It's quite important because we are going to discuss some of the issues like transportation or how we can reach out to these patients. And we need to consider not only that these are patients who are with other chronic conditions, but also may have some kind of disability. Another issue that is extremely important to mention is that 25% of them are Hispanic. So there has to be some kind of services for the Hispanic population, specifically for those whose language is not English, so and they have difficulties communicating with the health team. And the other number of percentage that is extremely important is that 55% of those living in public housing have less than a high school diploma. This is extremely important to mention because we are, as you know, health literacy is something that is also that we need to consider when we have a communication with patients, specifically with those over the age of 65. In this era, the COVID-19 era, we also need to make sure that we have a better understanding of how patients access the internet, how patients, whether or not they have access to telehealth, whether or not they know how to use all the apps and everything that is related to diabetes. Whether or not these people have somebody who can help them with all the information that they receive. So and HUD is working closely with public housing agencies to make sure that these patients have access to the internet now that we are living in this COVID-19 era, to make sure that they can communicate with others, and at the same time to receive services from either the health centers or the doctors or whomever is responsible for their health. Next slide. Quickly, of over 433 health centers reported to be close to or immediately accessible to public housing. And in 2019, they served over 5 million patients. And 108 of these health centers received funding from HRSA to provide health services to this population. And again, in 2019, they provided services to over 800,000 patients. Next slide. This is just a quick reminder that diabetes is a disease, is an epidemic, is a rampant condition that is affecting our populations. And very important to say is that even though health centers are not required to report diabetes by age group, there are some reports specifically from the American Diabetes Association mentioning that 1/3 of those over the age of 65 have diabetes, and half of them do not know that they have diabetes. And there is another 1/3 of those age 65 and older who also have prediabetes. So we need to keep that in mind. In addition, remember that these specific population have other comorbidities. We are talking about hypertension. We are talking about behavioral health issues that we need to consider when we have a patient with diabetes, and make sure that we address all the comorbidities and not only diabetes. Next slide. So there is the National Center for Health and Public Housing has developed some maps specifically related to diabetes, and this is information that you can find on the NCHPH.org website, where you can find data of prevalence of diabetes by city or county. And this is extremely important when you are planning to develop some programs, either prevention programs or any kind of programs related to diabetes, so you can compare what your health center is reporting with what your county or your state is reporting, and making sure that you address all the social needs that this patient may have. Next slide.
Great. Thank you, Jose. In these next few slides, if you have other things to add, you're more than welcome to jump in. But Jose gave some of this context just a minute ago, but we know that cases of diagnosed type 2 diabetes have risen significantly over the past several decades, and is speculated that, of course, many more are unaware that they have this condition. Much of this increase is attributed to, we have an aging population and climbing rates of those who are overweight or obese. Prediabetes indicates that there's a higher blood sugar level than normal, which might put someone at greater risk for not only developing type 2 diabetes, but also things like heart disease or stroke. So we know that some risk factors listed on this slide for type 2 diabetes cannot be modified, such as age or family history, but some lifestyle behaviors can, like diet, exercise, smoking. Reducing the number of risk factors that can be changed can help to prevent or at least delay the development of type 2 diabetes and improve overall health for older adult patients. So we will have a speaker next week from the American Diabetes Association that might be able to speak a little bit in more detail to some of the recent studies around whether prediabetes is a useful marker for diabetes risk for older adults specifically. So there's some recent research that's putting a little bit of a question mark for older adults compared to this being a strong indicator for young adults and middle-aged folks, but it's still an important list to consider for those who might be at risk for developing type 2 diabetes as they age. So the article I have linked in this slide discusses the importance of understanding the experiences both of older patients and healthcare providers when working to overcome barriers to diabetes treatment and prevention. So starting from the perspective of the patient, it's important to consider the relationships they have with their healthcare team. Are they receiving similar messages from each person that they see? Have they been able to develop a sense of trust with their provider and have a clear understanding of the benefits of what they're being asked to do? A lack of rapport or conflicting information on a patient's lifestyle behaviors or risk factors for diabetes may leave them feeling discouraged or disinterested in starting or maintaining healthy habits, which we know are so crucial as we age. And while no two older adults are exactly the same, there are age-related changes that also might serve as a barrier to diabetes prevention. We'll talk a little bit about those later, but just want to mention that there could be cognitive changes related to processing speed or reduced capacity to process or remember new information. Certainly visual and hearing changes are common for adults over the age of 65, which can impact their interactions with providers as well as how they engage in their daily routines. And then concerns with mobility or balance can certainly limit an older adult's sense of confidence or safety when engaging in physical activity, both in their homes and communities. And like Jose mentioned, health literacy is a really important factor here. We want to make sure we understand that health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic information related to their health, and then apply that to decisions related to their health and safety. So low health literacy is unfortunately more common amongst older adults. So it's especially important to consider where language can be simplified, both in conversation and in writing. There needs to be a balance of using everyday terms that are still relaying accurate health information. We're not talking about necessarily dumbing things down, but using short sentences can go a long way, particularly if the tone is positive and is identifying who is doing what clearly. So for people living with or at risk for developing diabetes, language can have an impact on their motivation, behaviors, ultimately their health outcomes. So being mindful of the way that we talk to these patients about diabetes itself can impact the way that their chronic condition is either being prevented or managed, and then their overall well-being. For example, the often used terms of compliance or adherence imply doing what someone wants, what someone else wants, like taking orders as if they were a child. But in diabetes care and education, people make choices and then perform self-care and self-management. We want to focus on their strengths. What are they doing well, and how can we build on that? And to Jose's point about language, translation and interpreter services are really important tools for healthcare practices, especially with populations that have limited English proficiency, but they might not be enough to make sure that a patient fully understands the health messages that are being delivered, whether it's a certain word or phrase doesn't translate well, or the technicality of a provider's language can present a challenge to the interpreter. It's also just really important to consider where information is being communicated and who's doing the communicating. Certainly the context of healthcare has changed significantly over the past year with telehealth, telephonic visits. This might increase the risk for a patient misunderstanding a health message without the proper tools or strategies in place to recognize and bridge cultural differences in order to increase the effectiveness of their communication with a provider. We want to make sure that we're collaborating with patients as providers, involving understanding that culture can influence communication, whether that's because of language, values, stereotypes, beliefs, body language. So we can work to overcome barriers by learning a patient's culture and asking questions like, what do you know? Or how do you feel about this? Or what do you call this problem? even a quick shift to saying a person living with diabetes instead of a diabetic person might be able to respectfully indicate that someone is more than just their diagnosis. And just quickly, polypharmacy might be a little bit more of a barrier around the management of diabetes in older adults, but it's important to note that this population, they are at greater risk for adverse drug reactions, whether it's because of changes to their metabolism and how their bodies process prescription drugs. The risk is certainly exacerbated when a higher number of prescription drugs are used, which is often the case for older adults with multiple chronic conditions. The cost of medications and the challenge of keeping track of multiple medications directly impacts a person's ability to adhere to a regimen and effectively self-manage or delay the onset of a chronic condition like diabetes. And Jose mentioned the social determinants of health. These are conditions in which people are born, grow, live, work, and age. Many of these factors listed on this slide serve as potential barriers to preventing or delaying type 2 diabetes for residents of public housing, especially those that are over the age of 65. Tackling health inequalities involves addressing the unequal distribution of many of these health determinants, such as income and social status, education and literacy, physical environments, both in the home and the community, social supports and coping skills, and access to health services, and certainly transportation plays a big part in that. Food insecurity is a major concern for older adults, and we'll hear more about the ways that we can address this barrier specifically from our guest speaker in just a few more moments. Many of our past learning activities from our center have focused on an age-friendly framework for health systems, but there has been a global effort to generally increase the number of age-friendly communities as a whole, which might include hazard-free buildings and streets, safe roadways with ample access to transportation, all of which help the entire community to feel more confident in their ability to engage in healthy lifestyle behaviors. So just a little bit from that same article around barriers, potentially from a provider experience. So the experiences and motivations of healthcare providers may also end up presenting some barriers to diabetes prevention for older adults if there is a lack of support or resources specifically geared towards this population. So there are many myths out there related to aging and chronic conditions, especially when it comes to forming and maintaining healthy habits in later life. Providers may believe that these misconceptions, some of these misconceptions rather, or hear them from their older adult patients, whether that's there's no point, I'm getting too old to change, or it's not safe for me to exercise, or I have too many aches and pains, I might fall, or even just I don't like eating healthy foods or exercising, just as kind of a statement. But the truth is we're never too old to get moving, to improve our health. Older adults who become active later in life often show a greater physical and mental improvement than their younger counterparts. And the key, of course, is to start small and work towards achievable goals. Certainly, if a provider is not connecting with or doesn't have knowledgeable people on their team that can address the finer details of diabetes prevention and care, their patients might be missing out on needed supports at their visits to take a closer look at things like the social determinants of health. And certainly if a provider is not aware of available community resources, an older adult patient might feel more isolated in their efforts to modify their lifestyle behavior in between those visits with that provider. And how we view a patient's motivation to change might also impact how effective an interaction can be towards improving diabetes prevention. So if a provider believes that a patient is just unwilling to make even small lifestyle adjustments, they might not be consistently bringing up this topic at visits or try to explore what individual barriers might be for them. Perhaps a patient isn't asking questions about diabetes prevention or management during visits, and there could be a missed opportunity for any members of the healthcare team to express how they can support their needs. So let's just briefly discuss some approaches to encouraging behavior change with the goal of delaying or preventing diabetes. So every member of the healthcare team can play a part in this. A team-based approach can help to close communication gaps and consider best practices in relaying information to patients. We know that self-care behaviors are so essential for diabetes, both management and prevention, and the healthcare team can help to encourage and support patients as they work towards goals and implement new lifestyle changes. The plan for diabetes prevention should be primarily created with the patient and their caregivers, using a really patient-centered approach, since a patient's actions not only reflect their individual characteristics, but their environment at home and in their community. All of those factors should be considered in that individual plan. And if there is family involvement and support, perhaps a family caregiver, that's going to increase the likelihood of a patient meeting their goals if they have that support. So many of us may be able to personally relate to the idea that changing our behavior is hard, especially when it comes to diet and exercise. The important thing is for us to encourage patients to keep trying, whether that's offering personal examples about how you personally overcame a challenge, or simply validating that disruptions on the path to healthy habits are normal, whether that's a change in routine, injury, life transitions, especially for older adults. It's really not a question of if, but when there's going to be a barrier, but we can encourage patients that there are resources to help get us back on track if we encounter a bump along the way. So motivational interviewing is really a fantastic tool for these conversations, particularly as you explore areas of resistance to change. So perhaps in our next session, we can talk a little bit more about the communication skills that motivational interviewing can offer us, to help keep the conversations moving forward. But we do want to kind of search for the change talk from a patient. So anything that indicates the possibility of change, maybe there's discomfort continuing in their current behavior, maybe high levels of confidence in their ability to change, optimism about the future if a change were to occur. So when we hear this kind of talk come up naturally, we might want to ask a patient to elaborate on that and affirm the positive aspects of what they're considering. So tell me more about this, or I'm curious why you say that, or can you give me an example of that? When we have reached kind of the logical ending point of this conversation, we want to reinforce it with affirmations of saying, I appreciate your willingness to talk about this, and a summary that helps to highlight in an even-handed way some of the mixed feelings that a patient still might be having, but hopefully that will allow you to comfortably pick up that conversation again the next time you connect, since follow-up is such an important component of maintaining change over time. So we want to celebrate the smaller accomplishments that will ultimately add up to a larger health-related goal. So if your patient makes a step towards healthier eating, want to cheer them on. If you notice any benefits like lower weight or improved blood pressure, you might be able to link that in conversation to their recent efforts to modify their lifestyle behaviors. And just really briefly, I want to just mention that the CDC's Diabetes Prevention Program is a free tool for patients to help to learn and stick with healthy diet, physical activity, and stress management techniques to reduce the risk of diabetes. So a few years ago, this lifestyle change program became a covered service for Medicare beneficiaries with pre-diabetes. You can see some of the requirements on this screen. This behavior change program has been shown to reduce the incidence of diabetes by over 70% in folks over the age of 60, which is really fantastic. The services can last up to 2 years. The first year, there's more concentrated lifestyle coaching sessions, and if certain goals are met, a patient might be able to have an additional year of periodic support. So we won't go into the logistics today about becoming an MDPP supplier or any of the technical aspects of the program, but I'd be so curious if there's folks in the virtual room who have referred their older patients to this program, and if you've seen it be successful. So feel free to share that. And again, we can talk a little bit more next week around this program if that would be helpful. All right, I'm so excited to introduce our guest speaker today. If you've been involved in any of our past activities, especially around diabetes management, you might recognize her picture. But our guest speaker today is Tara Hammis. I want to read her bio for you now. She is the Director of Member Services for Nutrition with the Massachusetts Council on Aging, the Massachusetts Delegate to the Academy of Nutrition and Dietetics House of Delegates, and member of the Massachusetts Commission on Malnutrition Prevention among older adults. She's been a registered dietitian for over 20 years and has spent the past 10 years working on older adult community nutrition programs. So Tara, take it away.
Thank you very much. Look, my brown hair is all gone. Just like so many others during the pandemic, we've made some changes. So thanks for having me. I appreciate the invitation to come back and talk today about barriers for diabetes prevention for folks living in public housing. And whether you work in public housing or in a health center, hopefully you'll learn some barriers, some ways to overcome those barriers, and then also some new resources. I'm hoping that you have questions and you'll reach out to me for more specifics, because I love connecting folks to information. So that said, consider yourselves an Instacart of one. And I know a lot of us, whether it's Instacart or some other grocery delivery service, they've been rather helpful during the pandemic. And since their existence, really, I know they've really caught on quite a bit. But think about the process. You know, you're going to save time in going to the store and doing your own shopping and bringing it back. But as you're the Instacart of one and receiving someone's order and shopping for them and then bringing them the food that they might need, similarly, we're going to tackle the learning objectives for today. So that's identifying the issues, problem solving, and then figuring out how to act. So, you know, let's start first with identifying the issues. What influences the ability of older adults to engage in healthy lifestyle behaviors? Again, we're going to look at a couple of the social determinants of health. First one specifically is the physical environment. And the subset that I want to look at is the location. What is someone's access to healthy foods? What are the stores and the restaurants in one's community? The stores could be, they're more often small corner stores located close to public housing units. It's difficult to encourage a lot of the supermarkets to come into certain neighborhoods, primarily because of cost. So you can imagine, if you don't already know, that it's difficult for folks to have access to low cost, high quality foods. So they may pay higher prices. They may be shopping at stores that don't accept nutrition benefits such as SNAP or WIC. And they also may have a higher number of fast food establishments. So those foods, as we know, aren't typically the most supportive of diabetes management. Also, are those foods culturally appropriate? Whether you can get to them easily or not. As Jose said, 25% of folks in public housing are Hispanic. So if these stores aren't covering the foods that they prefer, it's very likely that they're more inclined to choose other foods that they may or may not be familiar with and could be detrimental to diabetes prevention. There is a food environment atlas, which we'll take a quick peek at for anyone who's looking for data or just wants to get an idea of what's around X community other than driving around and taking a look out your window. This is a really great map. It's county based. If Ariel, if you go to, just the first one, access and proximity to grocery stores. And then let's hit just population, low access to the store in 2015. Yeah, percentage, that's great. And then you can click on any county and some data will pop up. And then actually, if you go into that box, it will give you additional data. So you can see even how many folks are low income and have low access to stores. So this just gives you a finer detail of what we're talking about. And there are other maps other than the stores, but I wanted you to have this just so you could literally and figuratively get a better picture of it. So thank you, Ariel. All right. Transportation quality, this is, I would say is the biggest barrier as a dietitian for folks who don't have a car, don't have a reliable car, have to rely on a bus, which may or may not have a reliable schedule, which may have a schedule that has changed due to the pandemic and the frequency. Taxis are expensive. Are there ride shares available? Is there a subway available? Do you need to use a bicycle? Do you need to rely on somebody else? A lot of taxis won't cross city lines. So it's difficult if, the grocery store is the next town over, but your taxi cab company won't take you there, or they'll take you there, but then charge extra. And that's really going to eat away at someone's budget. They also might have a limit on the number of bags that you can bring when they're transporting you home. You might need to rely on shuttles, whether that's a local shuttle that your Council on Aging may have. Now with the pandemic, they can have fewer people on board at once, and a lot of those also have bag limits. Excuse me, some of them also, while you might want to go to the cheaper grocery store in town, they may have a limited geographical area that they go to. So you might end up not going to the store that will give you the biggest bang for the buck. And then think about also the weather, regardless of where you live. This poor woman here, she's got her groceries spilled all over. I'm in the Northeast, we're in Boston. And some of those winters can be very treacherous. And imagine if you don't have reliable transportation and you have 6 bags of groceries and you have an unshoveled sidewalk, and then you've got to bring all of your groceries up and you drop a bag or two because there's no more plastic bags that are being offered. You got to carry everything in paper bags or bring your own bags, which again, folks might not have the money for. And I want to mention a little bit here too about walkability. A lot of times we can walk to some of these stores, but it might be more difficult for folks who are older. The sidewalks, as I mentioned, might be broken. If someone's relying on a wheelchair, they might not have curb cuts. There might not be sufficient shade. There might not be benches for folks to stop and take a break. So all of these really do impact how you get your food and how often and how much you have to spend. Next slide, please. In addition to physical environment, one's social circumstances are going to have an effect. We don't always know by looking at someone what their income level is, what their language level is, what their literacy level, education, etc. And while most folks over 62 may not be working, they might be volunteering, they might be working part-time, they might be helping out another family member with childcare. So that may make their hours, their window of hours where they can get to a store that's open more limited. Someone's finances, they may be low income and able to qualify for a small set of benefits, or they might be just over the line where we call them in the gap. So if you've ever heard, the SNAP gap, they're just not able to qualify for SNAP, but they do qualify for health insurance benefits. And then of course the cultural barriers as well. Are the materials that we want to share with folks around diabetes education, are they in the languages that we need them to be in? What are the populations in your community that you have to make sure that you are addressing? Do you have a large Vietnamese community? And so do you need to make sure that you have materials in Vietnamese for them? Next slide, please. Genetics and biology, specifically someone's body function and structure, is also one of the social determinants of health that we need to pay attention to. There are a number of tools. We know tools for screening for diabetes, but also for hunger and the prevalence of hunger in our communities. The hunger vital sign, these are linked here for you in case you aren't familiar with them. The hunger vital sign is 2 questions, and the malnutrition screening tool is also 2 questions. And these 2 tools are validated. And so you can actually get a very reliable idea of where someone falls on the spectrum of having hunger or being malnourished or at risk for malnutrition. And if someone does score high on the malnutrition screening tool, this is something that they can take to their health center or primary care provider. And maybe not, that office will have a produce prescription program, which I'll get to in a minute. So also someone's movement and their balance. We know that older adults face a number of challenges. I take that back. We all face a number of challenges as we get older, regardless of what age, life stage we're at. Our movement and our balance will change. Our strength, we know we lose muscle mass, the fitness, especially, I mean, raise your hand if you have not, see, I've raised both. Raise your hand if you have not been as active over the past year. And I apparently doubly echo that statement. Your blood pressure might make it harder for you to move around. You might have an amputation or some other disability. So imagine how that will impact getting to a store, choosing your foods, bringing your foods home, and then also cooking. You know, we didn't mention before, but some of the shuttles you want to call might not have access. They might not be vans. They might not be wheelchair accessible. So that could be another barrier as well. Next slide, please. So now that we know that we have the physical environment, social circumstances, and then genetics and biology as 3 of the social determinants of health that will make an impact, we want to figure out how we can problem solve. And a number of these are doable and a number of them aren't immediately. So I know for purposes of today's discussion, you're not going to walk away taking on the charge of, you know, how do I change the built environment? How do I make a community change and get a grocery store into my neighborhood? Maybe you are, maybe you're not. That's, I think if you can, that's fabulous. But I'm not asking you to do that right away. You might be able to set up a food pantry or a community dining program, either in your health center or in your housing, your building, if you have a community room. You might also be able to have a farmer's market come on site, and with that, distribute senior nutrition farmer's market coupons. And more immediately, you might be able to educate others or promote programs. And I want to give you a number of programs for you to promote to older adults and in your buildings and in your communities. You might have, oops, sorry, just back up 1 second, sorry. Screen, if not help someone apply for assistance such as SNAP, and then again, identify what exists in the community. Thanks, Ariel. So you might have seen this slide from me before, you might not have, but I love this guy. Know your resources, and if you don't, I will help you. So we have SNAP, and I don't want to make this the SNAP slideshow or SNAP program, but I have to say, over the past year, because of the federal emergency declaration, USDA has provided a number of additional benefits to states who have also declared emergencies. So in Massachusetts, we have your basic SNAP, which was known as food stamps. SNAP was boosted in January with the new housing, with the new income levels, but also during the during the summer, USDA increased tens of thousands of households in Massachusetts from wherever they were in however much they were receiving in SNAP to the maximum level. So I actually had one gentleman call and say, I was only getting $15 in SNAP and now I'm getting almost $200. Is this wrong? What happened? And I said, no, it's it was the boost. So there's your regular SNAP allowance, and then there's the pandemic boost. And then on top of that, in January, the USDA provided an additional 15% boost from January to June, which was just extended to September. So there are all of these extra bits of money. And I really want to encourage folks to look at seeing if they qualify for the SNAP program, because there's a common misconception that it isn't worth the time and the effort to only get the minimum amount. You can ask your local assistance office in Massachusetts, it's Department of Transitional Assistance. They've given me reports of what the average dollar amount for an older adult who is single, living alone, would receive each month by city and town in the state. So this is a tool that we can take out to the Council on Aging directors and say, hey, did you know in Barnstable, your county, I take that back, let's go to Plymouth, specific town, that this is the actual dollar amount that folks are receiving. And a lot of times it's much higher than what people anticipated. So that's another tool that you can use just to encourage folks to reconsider it. A lot of folks think that other people need it more than they do. And what I encourage you to share with them is that this isn't one of those programs where it will go to someone else. It is something that older adults have paid into and they are entitled to. So if you qualify for it, please accept it. There could be other programs that are directly attached to it, such as in Massachusetts, Healthy Incentive Program. Once you are enrolled in SNAP, you automatically receive additional money that you can spend on fruits and vegetables. And then the pandemic, I know that was just the first one, that was just SNAP. But also pandemic EBT, this is something that school children are receiving, who were either eligible to receive the National School Lunch Program. I bring this up because we have a number of grandparents raising grandchildren. So this is an additional funding source that folks can use. And I also encourage folks who don't need the money, but want to donate the funds or the card to, say, their local food pantry. There are ways that you can make that happen without actually transferring the card. So there is that option for children. And don't forget that WIC will apply to children up to age 5. So again, if you are watching younger children, then you could be eligible for WIC as well. Okay, there are also programs that are funded through the Older Americans Act, which are the home delivered meals and the congregate meals. This is also known as Meals on Wheels. The congregate meals have really transitioned to be grab and go sites, and home delivered meals have increased over the past year. Again, encourage you to see if folks are eligible for these. A lot of them are medically tailored, and they don't just provide a hot meal. They may also provide a supper bag and some snacks and weekend and holiday and frozen meals. Commodity supplemental food program and the brown bag, those target older adults through your local food bank typically. The farmers market coupons and homebound produce program are another USDA funded program that gives money to folks during the summertime. CSAs have actually, some of the CSAs have senior shares. Your housing development or your health center could partner with a food rescue program, whether that's coming from unused, still frozen pans of unused lasagna from a restaurant, or bags of oranges that are going to be donated. So there are many, many, many more. And I have for folks, I'll put this link in the chat box. Ariel, the next slide, please. There's a self-assessment for your community. If you want to make sure that you're capturing everything that's available to folks, I think this tool has about 40 questions on there for you to think through, just to prompt you, is there a brown bag program? What is a brown bag program? And if you don't know what any of these are, feel free to contact me. All righty. Go ahead, next slide. And so the last piece is really to act. We really want folks to consider partnerships. Can you work directly with your local food bank? Can you work directly with your aging services agency? They may have volunteer shoppers. They may be the ones who have the nutrition contract and can provide those home delivered meals. Who are your mobile markets? A lot of these do accept produce prescriptions. So the doctor would actually write a produce prescription and the recipient could take it to the mobile market and get their vegetables. Partner with a private corporations, community development department. What are your intergenerational programs? Can you go on a farm tour? Can you organize a farm tour from your health center or your housing unit to bring older adults there? Forget the bingo trips and the casino. Let's go to the farm. There's a number of available grants. You have your councils on aging, and just remember there's strength in numbers. So there might be someone else in your community who is looking for a similar resource. You might want to band together. Next slide. I wanted to add, in addition to changes that you folks can take, there's also the small changes that the patients can take. And this is a list of things that we've heard, that you are free to use and share with folks. One of the tips I really like to encourage folks to do, in addition to them, if they're counting their carbohydrates, is really to make sure that they can get enough dietary fiber and are hydrated. Next slide. Thank you. So this is my contact information. I hope this was helpful in identifying some of the issues that you hadn't thought about, in identifying some solutions. I will definitely put some links in the chat box for you. And regardless of where you're calling in from, I'm happy to help you and encourage you to reach out. Thank you.
Wonderful. Thank you so much, Tara. We have a few minutes for any questions or comments. I see a comment in the chat of appreciating the suggestions to engage the community with available resources, which is fantastic. So we have a few minutes if folks have a question related to the content or want to share about their experiences with engaging this population around diabetes prevention, or, I think that there's so much research and literature out there that kind of the line's a little blurred between diabetes management and prevention. And there's a lot with lifestyle behaviors that goes into both. So certainly if you want to share around any experiences you've had with diabetes management as well. And Jose, if you are free to do so, we can also have you come on and talk maybe a little bit more. We've covered quite a bit around social determinants of health and how that interacts with diabetes, both prevention and management, but just thinking specifically for older adults who are living in public housing. Was there anything else that you wanted to mention related to the work that you all have done at your center with this specific population?
Sure, thank you, Ariel. We've been in contact with public housing primary care grantees, and we have been discussing diabetes in the aging population. They have shared best practices and resources and some activities that they do to serve this population. Some of the activities or some of the strategies that they use, for instance, is to make sure that they offer services to this particular population on in regards to food care, for instance, which is extremely important when you have a patient with diabetes. In addition to that, they make sure that the patients have their eye exam every year. And in regards to social determinants of health, for those living in food deserts, they are making sure that they have activities and some collaborations in the community to make sure that they receive healthy food. So those are the strategies, or some of the strategies that health centers have in place to make sure that they are not just giving the medications and the healthcare that the patients need, but also that they are addressing the social determinants of health.
Mm-hmm.
There are other activities that they have in place. They have for this particular population, one of the health centers, for instance, take these patients to a park, and they have some agreements with the local government, so they can walk and exercise and have communication. So they are addressing not only any of the chronic medical conditions, but also the ability for them to interact and somehow address other issues like anxiety and depression. So health centers have different strategies. Again, the recommendation is to assess the needs in the community to see what the patients need, and based on that, look for strategies. And speaking of the clearinghouse, you can also go there. I invite the audience to go to the clearinghouse, the health center clearinghouse, and you will find some best practices as well. So if you are interested in some diabetes best practices, go to the website, the Community Health Center Clearinghouse, and you will find many resources on how to address some of these issues in the community, and specifically for those living in public housing.
Yeah. And I'm wondering, Jose, maybe next week for our second session, we can highlight maybe in some more detail a couple of health centers that have been doing a lot of work specifically with this population in the hopes of both helping them to manage or prevent or at least delay type 2 diabetes. And I see a question, look at this slides. Yes, you will get an email right after this session with, again, the PDF attached, but we'll also give you a link where you can actually view all of our past webinar recordings, and we will have this session up on YouTube as soon as it's closed caption for folks. So yes, you will get access to all these materials. Jose, do you want to just give like a super brief preview of the speaker for next week's session for folks to see if they're available to join us? We'd love for them to come back on May 4th.
Sure. We are going to have the person responsible for reviewing the standards of care, specifically for those recommendations from the American Diabetes Association on the aging population. He's going to address all the recommendations and some of the best practices because he has some other activities he will be presenting first, but I will be happy to also share some of the best practices and issues and challenges that health centers are reporting, specifically public housing primary care grantees. Remember that even though they are focusing on public housing residents, these are strategies that you can either adapt or modify. So they are not strictly, to address the needs of public housing residents.
Absolutely. Yeah, I think that's an important note that even though we want to highlight the specific needs and considerations for this group, that generally we can use a lot of these information and resources to apply for, community dwelling older adults as a whole. So fantastic. Thank you so much to Tara, our guest speaker, and for all who joined us today. Feel free to look at the slides in the recording for this session. You'll get a reminder next week for our second session on May 4th at the same time. We hope that you'll join us then. Like I mentioned at the start, you'll have an opportunity to fill out a quick evaluation about this session will pop up automatically when you close Zoom, but we'll also email you the link. We'd love to hear your feedback and any ideas you have about future training or technical assistance activities. So again, thank you for your time. Have a wonderful rest of your day, and we hope to see you back here next week. Take care.
Thank you.